Hello. Off the screen here.
Yeah.
Hello. This is I'm Dr. Eric Osgard. I'm one of the gastroenterologists here in Reno with Gastroenterology Consultants. Our topic today, I think, is actually a good one. It's common anal rectal disorders, which I know everybody sees. I know it's not just me. But first, okay, so let's move on to our slides. And again, we're talking about common anal rectal disorders. I think this is a great topic because you will see this, I guarantee it. And the interesting thing about a lot of this is patients will come in complaining of something, and that's not what they have. Okay, so they may complain of bleeding, and of course well, they do have that, but I would say about 50% of the time that I see a new patient that has been brought in by our nurses as having hemorrhoids, at least 50% of the time, well, they have hemorrhoids, of course, but 50% of the time, that's not their primary issue. So, how do I advance here?
Yeah.
So introduction, I'm going to go through both kind of all the different symptoms, which of course there's a lot of overlap with the disorders and which symptoms occur with each of the different disorders. But then we'll also go into the different disorders individually and talk about identification and treatments. So symptoms, of course, pain. I think that's probably the most common thing that people think of. You really want to separate it into defecation pain or is it more of a constant pain? By far, the thing you need to think about most importantly with defecation pain is anal fissures. So that, of course, is typically a severe tearing pain with a bowel movement, usually a more constipated type of bowel movement, harder bowel movement, but not always. And almost always with that story, even if the patient comes in complaining of hemorrhoids, it is actually a fissure. However, of course, thrombosed hemorrhoids can indeed lead to severe pain with defecation and, again, a constant pain, which would be more common with a thrombosed hemorrhoid, for instance. Hematochezia, which, of course, again, is bright red blood per rectum, is very, very common with a lot of these. Pruitis Ani, which, of course, is a diagnosis in and of itself, which is Latin basically for itchy butt. Is super common, again, accompanying many of these different disorders, and then has its own differential, which again we'll touch on. Palpable tissue. So a lot of folks will come in saying they feel something back there. They're wiping with the toilet paper, and there's some decorations back there they're not too thrilled about. Yeah, typically that's hemorrhoids or skin tags, which again are different. They are not filled with the venous plexus, blood-filled venous plexus like true hemorrhoids are, and you have to kind of separate that out. You want to find out, is it protruding? Okay, in other words, is it coming out of the anus and then going back in typically after a bowel movement, or do they have to push them back in if they feel palpable tissue? That's telling you right there, are we dealing with an external issue, or are we dealing with more of an internal hemorrhoid or other thing, even a polyp? Proctalgia Fugax, which again, Latin is for fleeting rectal pain, something you will get asked about. It's very common, it's benign, it's not a big deal, but it is a severe pain, and I'll touch on that more later. And then, of course, incontinence, which really, if you're dealing with an elderly population, is extremely common and extremely disturbing to a lot of them, and you have to really often work hard to pull out that symptom from them. They'll complain of diarrhea, they'll complain of hemorrhoids, they'll complain of other things, but they won't tell you they're having incontinence. You have to ask specifically about it. So the disorders, real briefly, a list of them, and then we'll go into individually. Anal fissures, again, probably the most important one you need to know about. Hemorrhoidal disease, a little bit on internal and external. We don't do a lot about externals. We try to avoid treating them for the most part. Fecal incontinence, Pruitis Ani, and again, Proctalgia Fugax, and what we call Levator Syndrome, or Levator Ani Syndrome, or chronic proctalgia, also something you need to know about because you will be seeing this. So first, a quick look at the anatomy. So, of course, this is rectum all in here. It's covered with columnar line mucosa. It is insensate, so to typical pain. For instance, we remove polyps all the time. We take biopsies in this tissue. Patients feel nothing. You fill it up with air, you distend it, the baroreceptors will sense that, of course, but you don't have the nociceptors that are extremely present on the other side of this area here, which is the dentate line, and now you're talking about anus all in here. That is squamous mucosa. There are more nerves, more nociceptors, per square inch in the anus than anywhere else in the body. That is very sensitive tissue and really is important in distinguishing different types of symptomatology. Of note, we have your internal hemorrhoids here. These are internals. They, again, are covered with columnar line mucosa, so you do not have the same sensations. External hemorrhoids, smaller on the very outside, are covered with, again, squamous sensitive mucosa. It's important to understand that we all have hemorrhoids. So patients come in and say, do I have hemorrhoids? Well, I can tell you without ever looking, yes, you do. We all do. We are humans. Humans have hemorrhoids. The blood has to go through these areas. When we treat them, when we band them, you still have hemorrhoids after we're done. We're just shrinking them down. So your job is to kind of get them more manageable, essentially. Okay, so this fine thing is an anoscope. All of you should have these in your exam rooms, the clear ones. It makes it extremely easy to examine a patient, especially looking for fissures that are otherwise very difficult to see. Of course, your history is probably just as important, if not more important. They're cheap, they're obviously disposable. You just use it one time, throw it away. But this clear plastic allows you to see through it. I recommend everyone examine patients when they're doing a rectal exam, when they're doing an anoscopy, on the left lateral position. So have them just lay down in your exam room on the table on the left side. The old jackknife position is kind of, I don't know, kind of weird and demeaning. And you get a better exam this way. Have them lay on the exam table, left lateral position, wheel a stool up. Here we are, we think high-speed gastroenterology practice. For this exam, for all these things, we use these same anoscopy scopes and standard camping headlamps. Okay, you don't need anything fancy. Just strap on the headlamp and get right in there. Of course, we call them our butt lights. Okay, so anal fissures. Again, think about this, okay? Anal fissures are not hemorrhoids. There is the classic anal fissure triad where you'll have a skin tag on the outside, a fissure in between, and then inside you get an anal papilla like we're seeing right here in this picture. That's an anal papilla. It's not a polyp. That is covered again in squamous mucosa, very sensitive. We leave them alone. We don't remove them when we're scoping. This, of course, is what we call a retroflex view in a colonoscopy or sigmoidoscopy. These are hemorrhoids here. This is an anal papilla. So classic triad again, external skin tag, and between that and the papilla is an anal fissure. On your anoscope, it'll be inserted. Before you even look at it, all the way inserted with everything dilated up, you'll look on the side and you'll see a little oval tear. Okay, it'll look oval typically. It'll be red underneath. That's actually exposed muscle. Okay, very, very tender. In fact, you might not even be able to introduce a digit or the anoscope because of pain. When that happens to me, I treat them for an anal fissure and I have them come back in a month and we take a look again. Okay, that's how convinced you are typically with anal fissures. If you can't get a finger in there, it's probably a fissure, so you just go ahead and treat them. Okay, so again, background, common, especially in the young. If somebody is coming in their 30s, 40s, and they've got pain, it's almost always a fissure. 90% of them are posterior. Most of the rest of that 10% are anterior. If it's in an atypical position, so not posterior or anterior, you want to think about other conditions. Crohn's disease being the most common one, so you ask about more symptoms, and that would be somebody you need to refer. Even syphilis, HIV, other things, or even anal cancer. So again, make sure it's either posterior or anterior. If not, that might be something you need to refer. Symptoms, again, pain. It's severe pain. It's defecation pain. It's a tearing, significant pain. Patients are afraid to poop. You may have had kids that are having issues. You've got to treat these early and quickly because they start having more significant symptoms later. And of course, hematochezia, again, bright red blood with bowel movements for these. Okay, so diagnosis, well, you almost can make it on history alone. Exam, again, we talked about the anoscope, looking at our tear. This is, again, this kind of, obviously there's no anoscope here, it's just been pulled apart and you can actually see it. That doesn't usually work for me. I usually have to use the anoscope, and again, it's really pretty easy to see. If it's decent size and it's red, you got yourself an anal fissure. And again, we talked about the triad. And people can ask questions at the end here. So again, we're going to go on to treatment. So first and foremost, address the constipation. Okay, constipation I feel is the root of all evil. Not really, but close. So address constipation. I love Miralax, generic Miralax, no difference. Glycolax, polyethylene glycol, again, the same thing. Cheap, incredibly safe. There's no significant side effects other than diarrhea if you take too much. Available over the counter, can get it prescribed or whatever. If they put it in drinking water, I'd be out of a job, I think. Okay, so address the constipation, very important. If it's minor symptoms, you may want to go with just something simple like topical Vaseline, okay? Before and after a bowel movement, apply Vaseline. Now, obviously, if someone's at work, they're at school, they don't want to be bringing the big old Vaseline tub, that's just not going to work. They can buy little Vaseline lip treatments. That is a small little thing. Obviously, you just put a little bit on the finger. You can apply it with the bowel movements, again, before and after. And then put the thing back in their pocket, obviously wash their hands. That may be all they need, but they should keep doing it for weeks to months. Okay, fissures will come back. They always come back. It takes a lot of treatment. The mainstay of treatment is topical nitroglycerin. You have to have availability of a compounding pharmacy, or you can order something called Rectiv, which is a 0.2% concentration of nitroglycerin. We just have the local compounding pharmacies make different concentrations up for us. We typically start with a 0.125% nitroglycerin compound, which is a bit different, I think, than a lot. We like it because you get less side effects, but you still get most of the benefit. If they don't get any better with that, we then increase up to the 0.2%. They instruct the patient to put a pea-sized amount, again, on a gloved hand, insert just in the anus. You don't want to get them all over the outside. You don't want to get it all the way inside, just where the squeeze is. It's where the sphincter is. You know, one little swirl and get out of Dodge. They'll feel better for sure in a week. You got to keep doing it. Keep doing it 2 or 3 times a day for 3 straight months to really get your best chance of healing this up. Why does it work? It basically increases the vascular flow into the area, increasing healing, and importantly, cuts down on spasm. A lot of the pain from an anal fissure is actually from internal sphincter spasm. Okay, so right there, they'll feel better. In fact, we keep nitroglycerin in our clinic, and if we want to kind of push through an exam, we'll put a little bit in there, go out, see another patient, come back, and then do the exam because they'll already feel that much better, and you can get inside and get your exam. Side effects can be significant. Again, that's why we like to go with the lower concentration. Headaches, lightheadedness. You want to tell the patient after they put it on to stand up slowly. Okay, it's a vasodilator. I don't know if anybody have ever had any of the old nitroglycerin on you during the days when we used the tape and the paste and the ERs. You can get severe migraine-like headaches. So you want to minimize how much you put on there. That means that we use gloved hands. I mean, you know, with a glove, with a low concentration. Don't get it all over the butt cheeks. And it actually pretty uncommon. We don't get a lot of complaints from anybody as long as you do all those things. They can't be on phosphodiesterase inhibitors for erectile dysfunction for the obvious reasons. the same reasons why we avoid them with like oral nitrates. Topical diltiazem is coming into favor. A recent study actually showed it was just as good as nitroglycerin, but had less side effects. I just haven't kind of switched over to it because we have so little issues with the nitroglycerin. The concentration of this one is 2%. Again, I think you have to get that one compounded up. We have a compounding pharmacy that makes that up for us. Other treatments, we used to do a lot of Botox treatment into the sphincter. I don't know, it's just more invasive. It's a little bit harder to know where to put the needle. You guys won't have that as readily available. We don't really do it much anymore. And then some people simply won't get better. They've got a chronic fissure. You have to send them to a surgeon and they'll do a fissurectomy, which is what you want to avoid. There's higher risk of incontinence. Of course, it's surgery on that extremely sensitive area. You want to try to avoid knives in that area if at all possible, but it may be necessary in some people. So hemorrhoids, again, a lot of your patients are going to come in, they'll complain of a hemorrhoid or say, I have a hemorrhoid. Again, everyone has hemorrhoids. We are humans. We all have them. They're there. We may not see them because they don't need to be big enough. Why do we have hemorrhoids? Well, again, the blood flow is going through that area. It has to go through that area. And teleologically, obviously nobody knows why we evolved in certain ways, but they do help us maintain continence, okay? So they're like little pillows that kind of can keep things compressed and minimize fecal leakage and seepage. So they do serve a function. I don't know of any rating classification for external hemorrhoids. Internals are based on history. Grade 1, 2, 3, and 4. So grade 1s, you can see them on endoscopy. So usually patients don't complain of them, but those are grade 1s. Grade 2, patient complains of protruding internal hemorrhoids with a bowel movement, but they spontaneously reduce when they stand up, when they're done with the bowel movement. Grade 3s, they protrude but need manual replacement. And grade 4s, can't even be replaced, and those unfortunately often need surgical intervention. So hemorrhoids in and of themselves can cause a lot of symptoms. We'll touch on that. They can thrombose. Okay, this is when they become very painful. Pictures over here. So again, this is our anatomy. There's our sphincters. This is the internal hemorrhoids, and they're coming off all along here. They can protrude out like this one is doing, or it can be on the outside. If they thrombose, it becomes acutely painful, and again, both pain with defecation and just simply with sitting. There's a nice picture, what you'll typically see with a thrombosed external hemorrhoid. For the patient will tell you it's hard. It feels like a pea or a bean back there, and you can push on it as well. Very tender in the first few days for sure, probably the first few weeks. And it'll look this hard purple appearance. This is what you'll see. Internals, you'll see glistening. Again, they're covered with mucosa. Okay, so it's going to look glistening. It's going to have it's secreting mucosa. It's wet, but they'll be taut. They'll be also hard and palpable. That's thrombosis. Normal hemorrhoids are not hard like that. Anal papilla. Remember, I showed you the picture of the anal papilla. They will be hard, but they're not tender. Okay, they're not tender at all. Those are the differences. Things you feel that are hard in there. Let's go next slide. So symptoms, of course, bleeding. We all think of bleeding, and that's appropriate. Bright red, matochezia, usually with bowel movement. Sometimes it's not. This patient may even tell you it's squirting into the toilet water. It's a hemorrhoid. Typically, you'll see the bright red blood on the bowel movement or on the toilet paper. It would be more common. Again, pain, especially with thrombosis, but also with much less severe discomfort with protrusion. Pain with the thrombosed hemorrhoid, again, is constant. Patients won't be sitting. You'll walk into the exam room to see them, or your office, whatever your setup is, and they'll be standing. They won't be sitting in the chair you provided. That's suggestive of a thrombosed hemorrhoid. Well, I'll talk on treatment here in a second. Pruritus, so they can get itchy butt from hemorrhoids. How does that work? Well, two ways. External hemorrhoids or skin tags present a cleanup problem. Okay, it's just hard to clean up back there. It's all those decorations. So you've got to recommend they use wet toilet paper or flushable wipes. Very important. And not go over vigorous. Too much cleaning can lead to excoriation and lead to pruritus as well. But that's how external hemorrhoids can lead to pruritus. Internals, if they protrude, that mucus that is now deposited in the anal canal is now a breeding ground for bacteria, which will feast on the mucus. And again, that will lead to pruritus from the internal hemorrhoids. Fecal leakage, although I just proposed that internal hemorrhoids and external hemorrhoids are there to help us with continence. If they become large and abnormal shaped, then that presents, again, you've kind of lost your normal cushions and you start to have more issues with incontinence, leakage, seepage, those kind of things. Usually it's small amounts, not like a full fecal incontinence kind of episode. And then again, protrusion, which we talked about as well. So here in my picture here, this is an anoscope. You can see the rim of the anoscope right here. It's clear, so you can see the anal tissue going around. And then as you pull back, you insert all the way, and as you pull back, you'll see these very large internal hemorrhoids. They're not always as big, of course. And so certainly those probably are protruding for the patient and giving them issues, probably with potential cleanup, but also with bleeding. So again, with the historical points that we talked about, the symptoms, you can often distinguish between internal and external hemorrhoids based on their complaints, between anal fissures and other things. So history is very important. Physical exam. Again, you got to do a rectal exam. You've got to do endoscopy. Just take a look, and you'll right away you'll know. Oh, you've got skin tags. Okay, skin tags do not look. They're not blood filled. They're just little cauliflowers kind of around the outside. Some people get more than others. Hey, it's just the way it is. Those can prevent a cleanup problem as well. Hemorrhoids will look like they're more engorged. They have some potential blood in there. Sometimes it's hard to tell the difference between the internals and the externals. But again, if they're in the canal itself, they're externals. If they're wet in appearance, they have mucus on them, shiny, and they're past the canal or coming out of the canal, those are internals. Anoscopy, we talked about the importance about that. Sigmoidoscopy and colonoscopy are really rarely needed in this setting. Okay, now if you're concerned that, oh yeah, they may have some symptoms from hemorrhoids and bleeding or something, but you're concerned about something else, or of the age where we worry about colon cancer, above the age of 40, certainly after 50, well then they probably should go and get a colonoscopy at that point as well. But really, to make the diagnosis, you do not need colonoscopy. In fact, it's a little harder to see them. The best way to see them is right here, not on a colonoscopy. And we talked about the difference between externals and internals. So treatment. Externals in general, we try to talk the patient into leaving them alone because it requires surgery. The banding that we do in our office, they would hate us if we put one of those rubber bands back there because, again, it's very sensitive tissue. It's covered with normal squamous mucosa that actually has extra nociceptors. So try to leave them alone. They can do certain things such as the sitz baths or witch hazel, some of those old-fashioned things that can help shrink them down. Yes, preparation H can help some. Some topical treatments such as steroids or suppositories can be helpful. Those are all fine. But in general, you want to do things like I'm going to mention here, which is address constipation. If the patient is not straining, if they're not having extra large bowel movements, that will minimize the growth of those hemorrhoids and they'll do well. Toilet training. Okay, so really you got to convince the patient, don't read on the toilet, don't sit there for long hours, please don't strain, simple things like that. Banding, we band, this is a type of banding that we do in the office. It's done in the office, not in the endo suite. You don't want the patient to be sedated. You want them to tell you if they're having pain because you want to avoid the dentate line and the squamous mucosa. Surgeons do it as well. Surgeons do the banding, they do a little different method, that's fine. We like this method we're doing mainly because it's nearly painless, but we only treat one hemorrhoid at a time, but it takes 5 minutes. Patients come in on their lunch break, they go right back to work, it's nearly painless. They resume exercise the next day. So very different type of hemorrhoid treatments than we're used to in the past. Again, suppositories, hydrocortisone is something you can try. The old sitz baths, warm baths, again, can be helpful. It doesn't have to be filled up this high, of course. And then sometimes you simply need surgery, like I mentioned. But in general, a lot of what you can do is by simple treatments with constipation treatment, those kind of things can be enough to honestly take away their symptoms where they don't need anything more. Okay, Pruitis Ani, itchy butt, oftentimes is dermatologic. Okay, and you're gonna see on exam a rash. Okay, now some of the rashes you can take care of right then and there. You got to ask about contact dermatitis exposure, new soaps, new detergent, new clothes, new underwear, something like that. That could be causing some of the problems. And then, of course, Candida infection as well. But the primary, so it's actually more common in men than women, almost like 3-to-1 to 4-to-1 ratio. So you'll see it more commonly in men. A lot of the reasons for that aren't totally known. But primary causes, meaning directly related to usually a dermatologic issue, psoriasis, atopic dermatitis, seborrheic dermatitis, lichen planus. These are all things that leave abnormal looking skin back there. If you see that, I send them to a dermatologist because they're going to typically do a biopsy anyways to look into that. However, if I think it's Candida, and I have another picture on the other one I'll show you. You know what Candida looks like. It looks often, it's well circumscribed, it's red, have sometimes little blisters in there. I think it's worth a treatment right then. In fact, I typically, even if somebody tells me about this, say over the phone, I tell them to go to the store and get a topical jock itch treatment formula, clotrimazole, miconazole, which is, I think, your Lotrimins and those kind of things. Buy something like that, have them put it on twice a day for a couple of weeks. If it gets better, that's your answer. Pinworm, okay, certainly more common in kids. We think about that. You want to ask about is everybody else in the family, because it typically spreads amongst family or a dorm or, again, groups, because it is somewhat infectious. They'll tell you early morning or itching all night. You'll see excoriations. You probably won't see the pinworms. But if you get a history where a lot of them are having this, you may want to just treat them with mebendazole. You can do the old tape test. We have a pathologist in our office, but I don't go over there with my tape on the slide and try to look for the eggs and stuff anymore. I just tend to treat them. If they get better, the whole family needs to be treated. AIN, or anal intraepithelial neoplasia, is kind of a newer categorization of, like condyloma, basically. It's a precancerous condition, can lead to anal cancer. If you see some of that on the outside, you see any abnormal appearing rashes, not just excoriations, you probably want to send them to a dermatologist to look at that more carefully. Secondary causes, these are the ones that you can do a lot about. Again, we're talking fecal contamination from seepage, from hemorrhoids, from, again, cleanup difficulty. If they have external skin tags, if they have external hemorrhoids, they're going to have difficulty with cleanup. You want to help them with using wet toilet paper or unscented wet wipes. A lot of people will get contact dermatitis now from the scented flushable wipes. That may be all it takes to improve things in them. Again, hemorrhoids, okay? It's, again, hygiene, difficulty with cleanup, the internal hemorrhoids depositing mucus, that's something to think about and may need to be addressed. And then again, contact dermatitis, like I mentioned. Ask them about new soaps, bleaches, new underwear, all that kind of stuff that they may be sensitive to something. Dietary irritants, very interesting. A lot of things that contain caffeine will lead to itchy butt in people. So you got to ask them about that and eliminate some things. And you can pull up some nice lists from Up to Date or other things out there. But here's some of the common ones: coffee, sodas, cola primarily, beer, chocolate, tea, tomatoes, citrus. So acid-containing things can also lead to itching. So you got to tell them to avoid those things during an early evaluation to see if that helps. Again, fecal soiling, we talked about that. If they have diarrhea with incontinence especially, hygiene issues, again, prolapse, internal hemorrhoids, etc., fissures and fistulas. So this is Candida right here. It almost can, depending on where the location is, it could look like other things. But again, if it's in there, especially if it's well circumscribed, where you see like a border around in the area around the anus, I would definitely treat that empirically, as we mentioned. Coffee, over vigorous cleaning or under vigorous cleaning can be issues. Diagnosis, again, dietary, soaps or contacts, things to ask about. You got to look at the perineum, and then anoscopy, because you want to look for fissures, you want to look for hemorrhoids, because these can contribute to this condition. And again, treatment. So treat any of the suspected underlying conditions. Before you send them to a dermatologist, try treating for Candida. Try telling them to have the dietary avoidance. See if they can change soaps to something else, those kind of things. So you got to think about all those things that we mentioned. So fecal incontinence, again, often a hidden symptom. I find you have to pull this out of patients. They will typically complain of diarrhea. They'll say, I have diarrhea. And then they'll start to talk about, well, so how often do you go? Well, once a day. Once a day. Well, okay, that's not really screaming diarrhea to me. So tell me about it. And then you ask them about urgency. I mean, you got to get up and run. Yes, okay. There's two different types of fecal incontinence. Basically, we have passive versus urge incontinence. Urge is more common, which typically is a problem with the internal anal sphincter, whereby they feel the call to stool, which is, I'll go over kind of some of the biomechanics back there in a second here, but they'll feel as if, oh, there's a bowel movement, liquid or otherwise, or even just gas, the fart you can't trust, and they'll need to run. And that is urge incontinence, whereas passive is they'll actually have either a full bowel movement or a large amount of seepage without even knowing it. They get up and it's wet. Again, these things are extremely disturbing to people. They're not something they want to talk about. You have to ask them, but it greatly affects their life. They will stop going to church. They won't go out. They'll plan their life around the toilet. It's really sad. So identifying this and doing whatever you can is very important. Very common, up to 25% depending on the population, obviously depending on how the question was asked, etc. And then, of course, the evaluation is the usual history, rectal exam, and then sometimes anal manometry. Right now, we don't even have that available for us in Reno. We actually send them over the hill to get it done in Sacramento. However, I really think we'll have it real soon at Renown, be able to do these things. So let's talk about this right here. This is what we call the RARE, or the rectoanal inhibitory reflex. It's a very important kind of graphic here during an anal manometry that shows the normal activity of the two sphincters in response to bowel movement. So basically, when, let's say you have a bowel movement enter into your rectum, that causes, the normal response is that the normally taut internal anal sphincter relaxes. Okay, it relaxes, and that tells you, oh, I gotta go. What do? You conscientiously clamp down on the external anal sphincter, which you control. It's normal. It's normally taut. We don't walk around clenching our butt. So that internal anal sphincter relaxes. You clamp down on the external. If it's normal, it's the internal anal sphincter's pressure recovers. You forget about it. You go about whatever it was you're doing, giving a cock at UNR or whatever. You move on. However, as that bowel movement or gas or anything stays in there, it re-triggers a relaxation, typically a deeper relaxation. And that tells you a little bit more, ooh, I gotta clamp down, reminding you gotta go. Pretty soon you end up having to run. If there's internal anal sphincter dysfunction, then this recovery may be prolonged or very poor, and hence you cannot maintain, you can try it, you cannot squeeze your external anal sphincter and hold it for that long. It automatically relaxes no matter what you do. That's why people have urge incontinence. Passive incontinence comes from a problem with the external sphincter, whereby the internal relaxes and they can't, the internal relaxes normally and they don't feel it and everything flies right on out. So it's kind of important to understand the rare, as we call it. Treatment initially is address constipation and diarrhea. Very important point. I'm guaranteeing you're seeing people come in there complaining of diarrhea and you're giving them Imodium, but the underlying problem is constipation. That's right. What they get is overflow diarrhea. Overflow diarrhea. Practically all patients that come in and complain of diarrhea, I get a KUB to look for evidence of constipation, and I find it all the time. Okay? You're going to want to clear that patient out and then bulk up their stool, and I'll touch on that a little bit later. So primary treatment is really bulking agents. If you know you're not dealing with constipation, you can go with loperamide or diphenolxylate over the counter or prescribed. You want to treat hemorrhoids again because that can lead to disruption of your little cushions back there. Kegel exercise can be helpful with external anal sphincter dysfunction. And of course, biofeedback as well for that, which we send them to physical therapists here who do that, often associated with GYN groups. Diapers, I know it sounds funny, but adult diapers, it will give your patients a little bit more confidence to kind of go about their life. Don't feel embarrassed to recommend that. Even plugs, people will take toilet tissue or cotton balls, put a little Vaseline on it, and kind of put it just inside the anus to kind of help with seepage. Simple things like that can really make a difference in their life. Surgical options are minimal. There are some implantable stimulators that can help with internal anal sphincter dysfunction. And again, bulking agents with your fiber. I tend to go with your typical Metamucils, Citracels, whatever. I don't care which one they buy. They're all the same. And then this is biofeedback right here. Proctalgia Fugax, again, Latin for fleeting rectal pain. The patient will tell you it feels like it's in the rectum, and they're right. It's inside. It's not on the outside. It's not in the belly. It's not in the pelvis. It's back there, but inside. It's severe pain. It can drop you to your knees. It's fleeting. It lasts seconds. It usually kind of comes in waves, maybe over a day period or a 2-day period. It may come in certain positions, sitting down for a bowel movement. It can be disturbing, and it can be quite severe, and it's completely benign. We're not totally sure why it occurs. It's probably spasm of the internal anal sphincter. You can diagnose it usually based on history alone, although you want to rule out other obvious anal disease, typically fissures, again, a thrombosed hemorrhoid, things like that, but I rarely find that. Treatment is typically reassurance. Levator syndrome or Levator Ani syndrome or chronic proctalgia is more of a longer lasting form, usually less severe pain, lasting up to 20 minutes or longer. It's more of a continuous contraction. We think of the pelvic floor muscles, primarily the levator ani muscles. On exam, you can often, on the rectal exam, get inside, and they'll be tender on the inside. Typically, no one is tender on the inguinal. They may be tender in the anal sphincter area, but with Levator syndrome, you'll push inside, and that will cause pain. That might be suggestive of that. Treatment, again, is minimal as well. Sitz baths, sometimes biofeedback actually, and Botox can actually help patient learn to relax those muscles. You won't see too much of that. You'll see a lot of the Proctalgia Fugax, however. So I want to end here just going, talking again about the root of all evil, constipation. Think about it. It's super important. I can't tell you how many elderly people I see now that have fecal incontinence. They complain of diarrhea. They've got both. They're chock full of stool on KUB. And it's almost too late to really get that anal sphincter function back, unfortunately. So you want to treat it. We have great treatments with osmotic laxatives, such as the polyethylene glycols now. Fine if they like milk of magnesia, fine. That's, again, it's a osmotic laxative. It's simple. It merely holds water in the stool, keeping things soft. It's not stimulants. Watch out for your patients who are taking herbal remedies. They're all full of, cascara senna, which are stimulants that can lead to long-term problems if it's used daily. 2 or 3 times even a week is probably okay for stimulants. Think about it with patient presenting with diarrhea. Ask them, are you ever constipated? Some of them will say no. I still check with KUB, and this is what you may see. You gotta ask, you gotta read. Don't read just the impression on that KUB from your radiologist. They'll say normal or unremarkable. If you read in the lines, they may say at least moderate fecal retention. So if you have a patient complaining of diarrhea and they never have constipation and they're chock full of solid stool, that's a lot of information. That's a lot of information, and you can make a huge difference, again, in their lives by treating them. I call it the bad weekend. They start on Miralax, they hit magnesium citrate, they clean out. They're already having usually fecal incontinence issues, so it's not a good time for them. But then I bulk them up with bulking agents, fiber supplements, and keep on it. They got to stick with it. You got to keep seeing them because they're going to want to go back to that Imodium because of the fecal incontinence issues. But keep them cleared out. Again, prevent long-term issues, osmotic laxatives first and foremost. Okay, any questions? Okay.
Any questions? All right, thanks everyone. Just remember we have behavioral health tomorrow morning at 8. Thanks, see ya.